Medial meniscus posterior root tear has been termed a silent epidemic as it goes undiagnosed many a times on knee MRIs. Tear of posterior root of medial meniscus increases peak contact pressure of the medial compartment by 25%, which is equivalent to a total medial meniscectomy. Medial meniscus posterior root tear and varus deformity have close associations. Together they hasten the meniscus extrusion and arthritic progression. Thus, both the pathologies need to be addressed for optimum outcomes. Medial open wedge high tibial osteotomy has stood test of time, giving better clinical results with lesser technical variations, whereas the root repair procedure is constantly evolving, varying from transtibial suture pull-out method to use of anchors. Combination of these two procedures have technical complexity during execution, that is tunnel collision. In a prospective study of 25 patients carried out in a single tertiary center in Indian population, we have discussed the technical details of arthroscopic medial meniscus posterior root repair with an all suture anchor along with medial open wedge osteotomy to have evaluated the functional outcomes of the same. This study was a prospective study. The inclusion criteria was patients under the age of 50 with confirmed clinical and radiological diagnosis of medial meniscus posterior root tear with a varus deformity of more than 5 degrees, with isolated medial compartment osteoarthritis up to Kale grade 2. Exclusion criteria: severe varus deformity more than 15 degrees and the body mass index of more than 35. 30 patients were included and underwent surgical procedures of medial meniscus posterior root repair using all suture anchor and medial wedge osteotomy. 5 out of the 30 patients were lost in follow-up. The methodology: diagnostic arthroscopy performed with standard anterolateral and anteromedial portals. The footprint of the posterior meniscus root curated out to remove the cartilage, and care taken to keep the cortex intact for use of all suture anchors. Soft anchor was prepared. Relay sutures passed through the tibial tunnel. Antegrade anchor insertion through the anteromedial portal, and then suturing was done of the posterior tibial. The tone posterior horn was sutured with 2 fiber wires using knee scorpion in crisscross manner to avoid suture cutout, and sliding knots were applied to fix the tone root firmly with the tibial footprint. 2 guide wires were then passed from the medial cortex at the level of the pes anserinus to the apex of the fibular head 2 centimeters below the lateral joint line. Medial and posterior tibial cortex was cut with a saw, followed by stacking of osteotome along the tracks of guide wire. Osteotomy was opened to the pre-calculated distance with stacking of osteotomes and maintained with a lamina spreader. Post-operatively, knee flexion started from day 2 with 30-degree increment each week up to full knee ROM at the end of the month. Non-weight bearing with crutches and brace for the first 3 weeks, partial weight for the next 3 weeks, and after 6 weeks, full weight bearing. During follow-up, signs and clinical radiological healing were evaluated. At the end of 1 year, MRI was done to evaluate meniscal healing status. Result: mean deformity, the femorotibial angle on weight-bearing radiographs improved from 12-degree varus pre-operatively to 5-degree valgus at 1 year follow-up. The mean medial proximal tibial angle increased from 80.6 to 87.2. There was statistically significant improvement in mean pre-operative Lisham score from 32 to 85 at 1 year follow-up. At 1 year follow-up, 90% of the patients had Mikulic's line passing around the Fujisawa point on scanogram. Meniscus plays a vital role in normal biomechanics and functioning of the knee joint. Combination of posterior root tear and varus deformity of the knee increases the adduction forces of the meniscus and has a higher chance of meniscal extrusion, which is equivalent to total meniscectomy. All suture anchors are extensively used in soldier surgeries with the advantage of bone preservation, comparable pull-out strength, smaller size tunnels, fewer complications like bone edema, loosening, and re-tear rate.